Welcome to Quick IM by Dr. Aid. This presentation on bacterial skin infection is for educational purposes only. Bacterial skin infections are common dermatologic conditions caused by various pathogens, primarily Staphylococcus aureus and Streptococcus pyogenes, ranging from superficial to deep tissue involvement. Superficial infections like Impetigo involve the epidermis, while deeper infections such as Ecthyma, cellulitis, and abscesses extend into the dermis and subcutaneous tissue. Folliculitis affects the hair follicles superficially, whereas furuncles and carbuncles represent deeper follicular infections that may progress to abscess formation. Next, we'll briefly review some key bacterial skin infections. Impetigo is a superficial epidermal infection caused by Staph aureus or Group A streptococci. It is usually painless. Non-bullous impetigo, the most common form, starts as red papules and forms honey-colored crusts. Bullous impetigo, caused by toxin-producing Staph aureus, features larger blisters and is more common in young children. Diagnosis is primarily clinical, but cultures may be considered in resistant or recurrent cases. Treatment depends on disease extent. Topical antibiotics like mupirocin or retapamulin can be used for localized disease, while systemic antibiotics like cephalexin, dicloxacillin can be used for extensive involvement. MRSA coverage should be considered for suspected and non-responsive cases. Preventing impetigo involves maintaining good hygiene, avoiding sharing personal items, and keeping minor skin injuries clean and covered. Ecthyma is a deeper form of impetigo, extending into the dermis and causing ulcerative lesions. It is often caused by Streptococcus pyogenes and sometimes Staphylococcus aureus. Ecthyma presents as painful ulcers with thick crusts, typically on the legs, and is associated with poor hygiene, poor nutrition, and immunosuppression. Ecthyma management includes clinical diagnosis and bacterial culture for severe cases. Treatment often requires oral antibiotics targeting Staph aureus and Streptococcus, such as oral penicillins and cephalexin. Doxycycline, clindamycin, or trimethoprim sulfamethoxazole may be used if MRSA is suspected or confirmed. Complications can include cellulitis, lymphangitis, and post-infectious glomerulonephritis. Gentle cleansing and local wound care are essential for healing. Erysipelas is a superficial acute bacterial skin infection affecting the upper dermis. It presents as well-demarcated, bright red lesions, often on the face or extremities. Group A streptococcus is the most common cause. Symptoms include redness, pain, and swelling, with potential for fever and lymphangitis. Erysipelas management involves clinical diagnosis. Blood culture is done in toxic-appearing patients. Penicillin remains a first-line treatment for erysipelas, but alternatives like cephalosporins or macrolides are available for those with penicillin allergies. IV antibiotics is required for severe or facial involvement. MRSA coverage is generally not required unless specific risk factors are present. Complications can include recurrence, local necrosis, and sepsis. Prevention focuses on treating entry points like tinea pedis and predisposing conditions like leg edema. Cellulitis is an acute bacterial infection of the deeper dermis and subcutaneous tissue. It is diffuse and often affects the lower extremities. Common organisms include Streptococcus pyogenes and Staphylococcus aureus. Symptoms include diffuse redness, warmth, and swelling, often with fever in severe cases. Note that cellulitis involves the deeper dermis and subcutaneous tissue with ill-defined borders, while erysipelas affects the upper dermis and lymphatics with sharply demarcated raised edges. Cellulitis diagnosis is primarily clinical with supportive cultures and imaging used selectively. Cellulitis treatment is guided by the presence or absence of purulence and underlying risk factors. Non-purulent cellulitis, typically caused by Streptococcus pyogenes, is treated with oral beta-lactam antibiotics, such as penicillin, amoxicillin, or cephalexin. Macrolides or clindamycin are alternatives in penicillin-allergic patients. Purulent cellulitis, often associated with Staphylococcus aureus, including MRSA, requires coverage with agents like clindamycin, doxycycline, or trimethoprim sulfamethoxazole, often combined with a beta-lactam like amoxicillin to ensure streptococcal coverage. Cellulitis resulting from mammalian bites requires broader coverage for anaerobes and Pastorella species, with amoxicillin clavulinate as the first-line agent. Complications include abscess formation, sepsis, and in rare cases, necrotizing fasciitis, particularly in rapidly progressive or immunocompromised patients. Preventive strategies include treating predisposing conditions such as toniapitis and chronic edema, maintaining proper skin hygiene, using compression therapy and lymphedema, and considering prophylactic penicillin for patients with frequent recurrences, more than 3 episodes per year, in accordance with current IDSA guidelines. Folliculitis is a superficial bacterial infection of hair follicles commonly caused by Staphylococcus aureus. Hot tub variant is linked to Pseudomonas aeruginosa. Viral and mite-related causes of folliculitis include herpes simplex virus, herpetic folliculitis, and Demodex mites, particularly in immunocompromised individuals. Risk factors include shaving and tight clothing. Symptoms are red, itchy pustules around hair follicles. It can occur anywhere on the body, in any hair-bearing area. Folliculitis management involves clinical diagnosis, culture and biopsy required in cases not responding to standard treatment. Mild, localized bacterial folliculitis typically responds to improved hygiene and topical treatments, such as antibacterial washes and topical antibiotics like mupirocin or clindamycin. For more extensive, recurrent, or resistant cases, oral antibiotics such as cephalexin or dicloxacillin are used, while MRSA suspected infections warrant agents like doxycycline. Hot tub folliculitis, usually caused by Pseudomonas aeruginosa, is often self-limiting, though ciprofloxacin may be considered for persistent cases. When folliculitis is non-bacterial, caused by fungi, viruses, or mites, treatment must be tailored with antifungals, antivirals, or antiparasitics, respectively. Prevention includes avoiding shaving over irritated skin, wearing loose clothing, using clean towels and razors, and considering decolonization or antiseptic washes in recurrent cases. Furuncles and carbuncles are deep bacterial infections of hair follicles, often caused by Staphylococcus aureus, including MRSA. Furuncles are painful nodules, while carbuncles are larger masses with multiple sinuses, often associated with systemic symptoms. They commonly occur in areas with friction or sweat, such as neck, axilla, buttocks, and thighs. Clinical features include redness and tenderness. Management of furuncles and carbuncles includes clinical diagnosis. Management of furuncles and carbuncles involves a combination of local care and, when necessary, systemic therapy. Warm compresses can promote spontaneous drainage of small furuncles, while incision and drainage is the mainstay for larger fluctuant lesions. Antibiotic therapy is indicated for lesions that are multiple, larger than 5 centimeters, located in sensitive areas like the face, associated with systemic symptoms or occurring in immunocompromised individuals. Empiric antibiotic choices should cover MRSA and may include clindamycin, doxycycline, or trimethoprim sulfamethoxazole, with the addition of beta-lactams like amoxicillin if streptococcal coverage is also needed. In severe or recurrent cases, especially those unresponsive to oral therapy, intravenous antibiotics like vancomycin, linezolid, or daptomycin may be required. Preventive strategies for recurrent furunculosis and carbunculosis include nasal decolonization with mupirocin, antiseptic body washes like chlorhexidine, good hygiene practices, and treatment of household contacts if colonization is suspected. A skin abscess is a localized collection of pus within the dermis or subcutaneous tissue, often caused by Staphylococcus aureus. It can arise spontaneously or from preceding infections. Clinical features include a painful, fluctuant, red, swollen nodule with central drainage. Systemic symptoms are rare unless severe. Management of skin abscesses involves clinical diagnosis. Ultrasound may be used to confirm presence of fluid in unclear cases. Management of a skin abscess centers on prompt incision and drainage, which is the cornerstone of treatment for all fluctuant abscesses. Antibiotics are indicated in cases of large or multiple abscesses above 2 centimeters, associated cellulitis, systemic symptoms, immunocompromised patients, or incomplete drainage. Empiric oral antibiotics with MRSA coverage, such as doxycycline, trimethoprim sulfamethoxazole, or clindamycin, are commonly used, and tailored therapy is guided by culture results when available. Intravenous antibiotics are reserved for severe infections with systemic signs, extensive cellulitis, failed oral therapy, or high-risk anatomical sites. Preventive measures include maintaining skin hygiene, avoiding skin trauma, treating underlying skin conditions, and considering decolonization strategies for recurrent cases. Erythrasma and pitted keratolysis are less common bacterial skin infections. Erythrasma affects intertriginous areas and appears as reddish-brown patches. Pitted keratolysis affects the soles, causing crater-like pits. Diagnosis involves clinical examination and Wood's lamp fluorescence for erythrasma. Erythrasma is treated with topical antibiotics like clindamycin or erythromycin and oral macrolides such as erythromycin or clarithromycin for widespread cases. Pitted keratolysis is managed with topical antibiotics like clindamycin, erythromycin, or mupirocin, and by keeping feet dry using antiperspirants to control hyperhidrosis. This slide provides a visual diagnosis of various bacterial skin infections, including cellulitis, erysipelas, folliculitis, furuncles, carbuncles, and abscesses. It highlights the distinct clinical features of each condition, aiding in accurate identification and differentiation. The summary table outlines key information on bacterial skin infections, including typical pathogens, clinical features, and treatment options. It serves as a quick reference for understanding the differences between conditions like Impetigo, Ecthyma, Erysipelas, cellulitis, folliculitis, furuncles, and abscesses. You may pause the video to study the table. MRSA in skin and soft tissue infections is a concern due to its resistance to common antibiotics. This slide outlines when to suspect MRSA and lists FDA-approved antibiotics for treatment. MRSA should be suspected in recurrent, non-healing skin infections, prior antibiotic failure, or settings with known MRSA outbreaks. Risk factors include healthcare exposure, recent antibiotic use, and chronic illnesses. Oral treatment options include TMP-SMX, doxycycline, clindamycin, and linezolid, while IV options for severe infections include vancomycin, daptomycin, and ceftaroline. Knowledge of local resistance patterns and proper use of culture data guide effective therapy selection. Board-style questions test knowledge on the management of bacterial skin infections. One case highlights topical mupirocin as first-line treatment for localized non-bullous impetigo. Another illustrates the role of I&D combined with MRSA-active antibiotics, like doxycycline, in managing recurrent abscesses. These cases emphasize key principles: matching treatment to clinical severity, avoiding unnecessary systemic antibiotics, and considering MRSA when appropriate. Bacterial skin infections can range from mild folliculitis to severe abscesses and cellulitis. Recognizing symptoms like redness, warmth, swelling, and pus is crucial for timely treatment. It's important to distinguish between superficial and deeper infections. Know when to drain an abscess or start systemic antibiotics, especially for suspected MRSA. Prevention is key. Practice good hygiene, avoid skin trauma, and manage conditions like diabetes. For the latest guidelines, check resources from the Infectious Diseases Society of America, IDSA, and the Centers for Disease Control and Prevention, CDC, for evidence-based protocols. If you found this helpful, don't forget to like, share, and subscribe.